hands up. I'm going to fire one at Graham. You work within the, call it Pākehā designed health system currently. Do you see the Health New Zealand reforms and the development of the proposed Maori Health Authority as, to use your analogy, that bridge between the two groups? Is that the start, or is it something else?
I think it's something else. I think if you read Y2575, read the whole report that was generated out of that, and the Māori Health Authority as a response to the treaty breach, that is the failure to improve Māori health outcomes, and also the failure to improve the quality and the quantum of kaupapa Māori health services in this country. I think that, to my mind, that would be the central task of the Māori Health Authority, is committed to, if you like, mana motu hake, so, kind of independence in Māori health development at all levels. Though obviously there's a role in terms of relationship with Health NZ, but I actually think mana motu hake is and tērā rangatira should be the central component of what the Māori Health Authority is trying to achieve. Am I taking the place of Andrew Little in this discussion?
Yeah.
Do myself on. Okay, as the top of the list there is Dermot. GP practices are businesses. Implicitly, is this the right model to deliver sustainable healthcare to our communities here in New Zealand? You alluded to this in your...
Yes, it's a good question. I'll speak for my own personal opinion. No, I do not believe it is. I personally believe that primary healthcare should be free at the point of care. I think and I will reiterate on this is my personal viewpoint. I think the cost barriers are significant, are overlooked in general by GPs, and they need to be removed. Now, that doesn't directly answer the question about sustainability. It is possible, I suspect, to reduce emissions within the system we have now, but we have to, I think, look at the entire system. That tinkering around the edges of the system we have in place at the moment is unlikely to be sufficient. There'll be significant pushback from GPs. Unlike in places like the NHS, there isn't really a mechanism to oversee it from the government, bar funding, and that makes it difficult. In the NHS, they will tie the funding to things like, and they have just recently, to meter dose inhaler use. So the switching to dry powder inhalers is forced by the NHS, and I find it difficult to see that happening quickly enough within general practice under the system we have at the moment.
Okay. This one, I think, is directed at David. How do you maintain optimism and create positive change when you do not hold any particular position of power? So I guess, sorry, I was mixing that up with another one, but I think, David, you could have a crack at answering that anyway.
Well, I don't necessarily believe that people are without power. There's hierarchies of power, I suppose, in a funny sort of way. So we all have some power. I think David Pension gave us a long list of the things that we could do individually and together and to organize. And I think India also gave us some mechanisms to do that. Certainly from my point of view, I think you do need to surround yourself with people that fill your cup rather than empty your cup. And I think that this work, I think from, talking around some of the sustainability managers and people who work in a number of the different district health boards, there are some places where people feel very alone and very unsupported. And there are other areas where they feel very supported. And even if the progress is slow, when you're surrounded by like-minded people and you're working together, it does give you the energy to push harder and to take those extra steps and to make the gains that you need to do. And when I think about, it's been over 10 years or so, maybe longer now, since we started our work. And the progress has been it was really slow to start with, but it's picking up fast. So you do need to sustain yourself over a long period of time. So you've got to keep yourself well, in every aspect of your life. And I think the best advice is to surround yourself with people who join Action Station, do something, like that. There are people out there who feel the same way that you do. Find them, There's a question up there.
Post your question on Slido would be my tip. Graham, tēnā rawa atu koe. For those of us tangata tiriti involved in new endeavours building on Matakimaya, what would it take to get us on the bridge?
So first and foremost, I think understanding of tuakana teina. So in relation to our own aspirations as tangata whenua, or our needs as tangata whenua, tangata whenua are always the tuakana, which is to say they're the leaders, the directors, and the authority in those decisions. And our tangata tiriti colleagues, our Pākehā colleagues need to understand what it means to be teina in those environments, which is to say the energy, the drive, the support, and the challenge to their tuakana. And at the heart of that is understanding Te Tiriti o Waitangi as a power sharing agreement. It's not a partnership agreement, it's a power sharing agreement. And the power sharing agreement has a range of aspects. So our use of Te Tiriti o Waitangi in our settings should start from the articles first, not from principles. And the articles would say in relation to Article 1 that if we are not providing space for Māori to be guardians over their own health or whatever journey, then we're not actually fulfilling the principles of Article 1, which is around kāwanatanga. Kāwanatanga supports that involvement of tangata whenua in all decisions. In Article 2, it's not just about roles, ideas, it's actually, are we resourcing tangata whenua aspirations? And are we allowing them to take those resources and use them in the way that they want to use them? And then thirdly, in relation to Article 3, the first thing I always start with at home is, do you genuinely actually understand the inequities that tangata whenua are facing in your space? Because if you don't, if you are using data to answer the queries of the ministry or of other government agencies, but not actually the queries of iwi, hapu and whānau, then you are not actually committed to unmasking the inequities that we're living with and overcoming them. There we go, that's my quick answer.
Just looking at the time before we get to lunch. Oh no, we've got plenty of time. Right, so Dermot, if prescribing is such a large component in GP emissions, should we push for embedded emissions to be part of the decision-making matrix for Pharmac?
Yes, is the simple answer. I'll answer this, and there was another one about inhalers, I think, just slightly lower down. I'll do the two together. Sylvia's question about Pharmac, the answer is yes, we should push. Yes, we have pushed, and yes, we should continue to push. It's very difficult to get a breakdown of, for example, medications, the climate impact of various medications, but it should be part of the decision-making matrix. There are plans in the UK to bring in a traffic light system for medications, so that would help with patient choice and things like that as well. With respect to meter dose inhalers, so meter dose inhalers are about 5% of the total healthcare footprint. It's the hydrofluorocarbons within them. So similar to the propellants basically within meter dose inhalers. This is an area that I think is becoming, there's a bit more knowledge about it at the moment, but it's still not something that is part really of the decision-making, prescribing decision-making within New Zealand. So a Ventolin inhaler, Ventolin brand inhaler, for example, is 28 kilos of CO2 equivalent per inhaler. So each individual inhaler, you've got your, I don't know, Toyota Corolla doing 100 grams per kilometer. So that's, each inhaler is 300 Ks in a Corolla. That's a kind of an easy way of getting your head around it. Most of the meter dose inhalers are around about the 20s, things like Seretide and the others. A A dry powder inhaler is less than a tenth of that, that carbon impact, that carbon footprint. And the difference that has happened is that the guidelines that came out last year support a change to combination inhalers, dry powder combination inhalers, of which the only brand in New Zealand is Symbicort. And it mentions in passing that it has a much lower carbon footprint. But so we have a health benefit. It's better to get people on these and to use a single inhaler for treatment and maintenance. We all have a carbon benefit. And in my experience, talking to patients and saying to them that this will make a huge difference in terms of climate emissions is a very easy way, particularly for younger people, to switch onto dry powder inhalers. And I work with students primarily. They're obviously accepting of this, they're aware of it, but it is something that they're very happy to do. And for most people on a regular inhaler, it's the single biggest change they can make in terms of their lifestyle, if you want to call it that, is switching from a meter dose to a dry powder inhaler in terms of their own personal emissions. So we'll be comparable to going to a fully vegan diet from a very high meat diet. So it's a single change, it's better for their health, it's got climate benefits as well.
I think we've got time for one more question. I'm going to go with the top one, and then I'll address the one beneath it after that. So this is the sweet spot where reduced carbon meets improved health seems to often go in the too hard basket. So shifting to a plant-based food system. So I guess the summary is, how can we promote the health co-benefits of climate action? Because I agree, I think health co-benefits get lost in a lot of the discussion around climate change.
Yeah, I mean, I think that's the big opportunity for us, for all of us, is to actually make that case in lots of different ways, to actually point them out. There's lots of evidence for that, so you can look at evidence. If you were to go to look at the role of the Health Coalition Aotearoa, which is Health Coalition Aotearoa or healthcoalition.org.nz. It's an organisation that's devoted itself to producing evidence-based policy to reduce preventable harm from unhealthy food, tobacco, and alcohol. We need to talk this up. I mean, we haven't really strategically represented this as an opportunity. This whole business of responding to the climate emergency is seen as a compliance thing, or is presented to people as a compliance thing, or perceived as by people as a compliance thing. So actually, we need to just change the narrative. We need to talk about those things. We need to listen to Graham. We need to listen to India. We need to listen to Debbie Wilson. We need to talk it up. And that's our role. And and actually, there used to be a time when we had a medical leaders forum or healthcare leaders forum in New Zealand, actually, where we would different organizations, member organizations would meet, and they would decide priorities, and they would actually really go for them. So we need to get really strategic, about this messaging.
Briefly,
yes.
To stop talking about health, start talking about well-being.
Yeah. Dermot?
Don't really have anything to add to that.
Okay, couple of things. Okay, we haven't really got time for any more questions. Okay, his hand up for so long. Okay, go for it. Shout loud.
Oh, well, so first of all, thank you, Dermot, my colleague, for making that speech. I want to directly address. I thought that was extremely courageous, maybe more courageous than many people in the audience maybe fully appreciate. And secondly, as a fellow of the College of GPs myself, I do my bit. I tend to wash out ear speculums all the time. Recycle those. My patients won't realise that. I dry them out once they've been washed in soap and water all the time. Thirdly, though, and I just posit this to you, is that working predominantly rurally, many rural doctors and nurses are so busy. They're mostly struggling to keep their head above water. Their voice is very rarely heard. And actually, they're on the front line with climate change.
And my big concern is not only are they not being heard, is that we're not providing them with the tools and the resilience to actually cope with what's happening rurally at the moment. I don't see the training. I don't see any of that training either within our colleges or within our medical schools in preparing people and giving them resilience to cope in these places at the moment. And that's my biggest concern. And I think you sort of touched on that, but I passionately wanted to kind of just bring that point home. So thank you very much for giving me the opportunity.
Okay, I have to say one thing. All these sessions are recorded and they will be on the website, so you don't have to take notes. You can go back to them afterwards. We'll be going to lunch, and I think this is an opportunity to any and all of you to discuss that question at the top. What does a just and sustainable New Zealand healthcare sector actually look like to you? Can you paint that picture for us? And as India mentioned, we should use our imaginations.